I'm Dr. Fakir and this is Pulmonary Tuberculosis in adults. Tuberculosis or TB is caused by Mycobacterium tuberculosis complex. Approximately 2 billion people are estimated to be infected with Mycobacterium tuberculosis, including 13 million people in the United States. It is transmitted almost exclusively by cough aerosols, and pathologically, it is characterized by necrotizing granulomatous inflammation, usually in the lungs, causing pulmonary tuberculosis, although extrapulmonary sites can be involved as well. Untreated tuberculosis has a 10-year mortality of 70% in smear-positive people and 20% in smear-negative people, and these rates are much higher in patients with HIV. And of course, with treatment, mortality is lower, but still around 2.5% of people without HIV, as well as 14% of people with HIV can die from tuberculosis even with treatment. Increasing age, more extensive disease, and HIV co-infections are associated with increased mortality. Mycobacterium tuberculosis complex consists of multiple species, many of which can infect both humans as well as animals. Mycobacterium tuberculosis infects humans and is the most common cause of tuberculosis. Mycobacterium tuberculosis is often referred to as acid-fast bacilli, and that is because of the staining that's done in order to identify these organisms under the microscope. So the acid-fast stain is what is used, and that is because of the differences in the cell wall of mycobacteria. So in general, mycobacterial cell wall consists of a large layer of mycotic acid, as opposed to peptidoglycan. So because the peptidoglycan is covered by this large layer of mycotic acid, gram staining is not really achievable. So mycobacterial cannot be identified as either gram positive or gram negative. So we do use acid-fast staining. In addition, mycobacteria grow very slowly. So you can see visible growth 3 to 8 weeks on solid media, and in liquid media it takes 10 to 20 days. Whereas for normal bacteria, it typically takes a day or two to see visible growth. Let's take a look at some definitions. So latent tuberculosis infection is referred to someone who has the Mycobacterium tuberculosis organism, but they do not have any symptoms. So this is asymptomatic and also non-transmissible. So someone who has latent TB cannot transmit the infection. Active pulmonary tuberculosis, which is transmissible, is actually in the presence of symptoms in the pulmonary area. And these symptoms include fever, night sweats, weight loss, cough, and hemoptysis. And hemoptysis is coughing blood. Drug-susceptible tuberculosis refers to organisms that are susceptible to Isoniazid or Rifampin. And multi-drug resistant tuberculosis is referred to organisms that are resistant to at least isoniazid and rifampin. So it has to be resistant to both of them, isoniazid and rifampin. And extensively drug-resistant tuberculosis is referred to basically organisms that are not only resistant to isoniazid and rifampin, but also resistant to any fluoroquinolone and resistant to at least one second-line injectable drug. So either amikacin, streptomycin, kanamycin, and capreomycin. Although multi-drug resistant and extensively drug-resistant TB is a global issue, in the United States they are extremely rare. So the majority of cases in the United States are actually drug-susceptible tuberculosis. So in this topic, we will only focus on drug-susceptible tuberculosis. Let's take a look at some reliable resources for tuberculosis. IDSA has several guidelines. In 2016, they released guidelines for treatment of drug-susceptible tuberculosis that we will focus on during this topic. They also have guidelines for diagnosis of tuberculosis in adults and children. They also have separate guidelines published in 2019 for drug-resistant tuberculosis, which we will not cover in this topic. And most recently, in early January of 2025, they released updates on the treatment of drug-susceptible and drug-resistant tuberculosis. So these are in addition to the previous guidelines, so they're not a replacement. So there is recommendation that will add to the previous 2016 guidelines from here. And then there are other guidelines available from the CDC and WHO. And of note, for latent tuberculosis, we will use CDC guidelines. And for HIV individuals, we also have DHHS guidelines for opportunistic infections. While TB is not an opportunistic infection specifically, it is covered in these guidelines, so we will touch on those recommendations. The first learning objective is describe the pharmacokinetic and pharmacodynamic properties of antimycobacterial agents. Here's a general overview of mechanism of action of agents used for tuberculosis in general. There are 4 agents that are used as first line for drug-susceptible tuberculosis, and everything else is reserved for drug-resistant, either multi-drug resistant or extensively drug-resistant tuberculosis. So the first drug that we use is the class of rifamycin. So rifamycins in general inhibit RNA synthesis by targeting RNA polymerase. So they inhibit RNA polymerase. The second class is, or the second drug is isoniazid. So isoniazid inhibits mycolic acid synthesis. So as you remember, in the cell wall of mycobacteria, there is mycolic acid, which is a thick layer above peptidoglycan. And by inhibiting its synthesis, these drugs can actually kill mycobacteria. Ethionamide has similar mechanism of action as isoniazid, but it is not used for drug-susceptible tuberculosis. It is second-line agent reserved for drug-resistant tuberculosis. The third agent is Ethambutol, which also inhibits cell wall synthesis, and the fourth agent is Pyrazinamide, which also inhibits cell membrane synthesis. So the 4 agents are rifamycins, isoniazid, Ethambutol, and Pyrazinamide, which we refer to as RIPE, which I will discuss shortly. Now, everything else is actually reserved for drug-resistant tuberculosis, including fluoroquinolones. So with the exception of ciprofloxacin, which is not active, so levofloxacin, moxifloxacin are actually active against Mycobacterium. Streptomycin is an aminoglycoside, so both streptomycin and amikacin have activity against Mycobacterium, and they are reserved as injectable drugs for drug-resistant tuberculosis. Macrolides are active against some Mycobacterium, so we have seen azithromycin and clarithromycin used for MAC, for example, not typically used for tuberculosis. And then we have ethionamide, and we have vidaquilin, as well as oxazolidinones, which are basically the most common one would be linezolid, is what's reserved for drug-resistant TB. And more recently, we had pyritonamide approved by the FDA, which is a bicyclic nitrominidazole, and this is also reserved for drug-resistant TB. Let's take a look at rifamycin. So in general, we have 5 rifamycins. Rifamycin is also a drug, so the whole class is referred to as rifamycin, but just like tetracyclines, where there is a drug called tetracycline, there is a drug called rifamycin, which is primarily used for traveler's diarrhea, and we don't really use it that much, so I'm not going to talk about it. But the other 4 are more commonly used. So Rifampin, Rifabutin, and Rifapentine are used for TB. Rifaximin is also rifamycin, but it is not used for TB because it's an oral drug that's not absorbed. So in general, we use it for hepatic encephalopathy and for recurrent C. diff infection. It can also be used for traveler's diarrhea and some other indications off label, but not for TB. All rifamycins have the same mechanism of action. They bind to the beta subunit of bacterial DNA-dependent RNA polymerase, so they inhibit RNA synthesis. So if there is resistance to one, there is cross-resistant across all of them because they have the same mechanism. But no cross-resistant with other classes of mycobacterial agents. One thing to keep in mind is that mycobacteria penetrate into phagocytic cells. So a property of agents that we use for tuberculosis is that the agents need to penetrate inside those cells in order to have activity. Isoniazid is a prodrug that's activated by an enzyme called CATG, and mutation in this CATG can lead to resistance. There can also be efflux pumps, and there has been some cross resistance between isoniazid and ethambutol. So if it's resistant to isoniazid, there's a good chance that it will be resistant to ethambutol. Pyrazinamide is also a prodrug that's activated by an enzyme, and mutations in this enzyme can lead to resistance, but no cross resistance has been observed with pyrazinamide. And ethambutol can also have resistance by mutations in one of these genes, and they obviously can have cross resistance with isoniazid.